treatable risk factors, but changing human behavior is very, very difficult. And I'll just ask one question. If you had to change someone else's behavior, what's the single most important thing you could do? What changes human behavior radically? Love? All right. That's the answer. I'm not talking necessarily about romantic love. I mean, that's sort of, it's very intense. People change, not necessarily for the better, but then it settles down. I'm talking what the Greeks call agape, love of your fellow human being. I'm talking about friendship. I'm talking about collegiality. And I'll give you an example in just a minute. And that is that Cheryl Meyer, who's a nurse, and Richard Chan, who's a junior colleague, we decided to do a study in our stroke prevention clinic on the premise that the way to change human behavior is to have another interested human being working with you. So we randomized, we did a pilot study initially in 4 centers, and we had usual care, which was see them in the clinic, write a letter to the family doctor, and not see them again unless they get sent back. Or in addition, work with a nurse who advises them about lifestyle, has someone to talk to. And I insisted that we add a volunteer, a layperson. Because at the time, my mother was living in Port Perry, Ontario, and I said, look, they're having trouble staffing the hospital with nurses. I don't think even if we showed that, I wouldn't be surprised if nurses are helpful, but they're unavailable. They're also professionals who need to be paid. I said, just indulge me, let's have a layperson. Well, Cheryl Myatt was very resistant. After all, they're not professionals, but to her credit, she agreed, and we did the study. So let me do a quick survey here. How many would bet on the doctor's approach being the best? Oh, ye of little faith. How many would bet on the nurse? Wow, who would bet on the layperson? Well, you're right. It turns out that the trend was so strong in terms of the volunteer, the peer, helping with blood pressure control and weight loss, that in fact, on the basis of that, we then got a Canada-wide study that we're now doing, which Richard Chan is directing, in which we simply compare usual care with usual care plus a volunteer. And the other thing we're measuring is that, you see, I told you earlier that these risk factors contribute to your changing cognitive function. So we're looking at control of risk factors like blood pressure and weight control, but we're also going to look to see whether controlling those risk factors preserves your cognitive abilities. So this is a rather important study, because if we show that we can control risk factors by using another human being, this can be applied very widely and not only prevent cognitive decline in a number of cases, but also heart attacks and other things that occur from not controlling risk factors. Now let me come back to the implications of our experimental findings. It is now possible to actually study in humans what we have studied in animals. There is a facility at the Lawson Institute, which is a unique unit in Canada at the moment. It's called a Siemens MRI PET scan unit. Now, what that means is that you can do studies of the brain structure, in other words, an MRI, with brain function. And you can study 2 things. One is amyloid deposition, which I mentioned before. You can also study inflammation. So at the moment, we have been doing studies in Montreal because we did not have the facility for synthesizing the ligands, they're called, the chemicals that we need to image the inflammation and the amyloid. We've been collaborating with a fellow called Alex Steele in Montreal. And so far, it looks as if we're on the right track. Of the patients who deteriorate after a stroke, they have amyloid in the brain, just like our animals. And it was quite interesting that we found that one patient had a small stroke that 4 months later you can hardly see on the MRI. But when we look at the inflammation, there was a big hot spot. So it looks as if what we found in animals applies to humans. Now, this is tremendously important because by the age of 73, half the people are carrying some amyloid. In other words, you have a flammable substrate of this amyloid protein, and then you have little triggers called stroke. So it's imperative that we actually prevent those little strokes from precipitating Alzheimer's disease. And I think that this may be in our hands. Of course, I can tell you the scientific basis for doing the study, but we have to do the studies to show it. The big shortcoming of this is that doing these studies in humans is extremely expensive. It's about $5,000 per patient. However, they can be done, and they ought to be done. Now, what we're planning are two parallel studies. One of them is by a young colleague we recruited. He was a graduate student that Dr. Chiquetto and I supervised. Now we recruited him back as a colleague. His name is Sean Whitehead. What we're going to do is that in addition to that special human unit at the Lawson, there's also a little animal unit to study the same compounds. So we're going to do a study in animals, in rats, using anti-inflammatory agents and using anti-amyloid agents. And we'll work out in the animals what's the right dose, what's the right time. And at the same time, we'll be studying humans. So as soon as we prove something in the animals, we can begin doing human clinical trials. And we already have a number of collaborators, or people are willing to work with us, if we in fact show, or confirm rather, because I think we're on the way, that our experimental work has been validated in humans. So let me conclude by giving you sort of a new avenue for preventing cognitive deterioration in those who already have amyloid. In other words, they're on their way maybe to develop an Alzheimer's disease at some point. So if we can treat them when the trigger comes off, in other words, the stroke, we may be able to prevent that or delay it. And eventually it may be that the agents that clean out the amyloid can be used as preventatives. So treating risk factors and this new avenue that we've opened up, will this actually result in delay of Alzheimer's disease, which is the question that I'm addressing? Clearly the scientific basis exists. We're well on our way to showing it, but we have not shown it yet. But I want you to understand the importance of delaying even by 1 year. If we delay the onset of Alzheimer's disease by 1 year, we'll cut the prevalence in 20%. Now, the basic concept is not that we'll live forever. Nobody lives forever. But the idea is what's called compression of morbidity. In other words, shove all the bad things to the end of your life. So when the kidneys go, and the eyes go, and the hearing goes, and the heart goes, and the brain goes, it's time to go, all right? That's what we're aiming at. Now, there is a parallel that makes me optimistic. 50 years ago, the mean age of onset of heart failure was 57 years. It is now 76 years. Imagine the number of lives saved, the productivity preserved, and the life enjoyed. Can we delay brain failure as we've delayed heart failure? I don't know, but we're sure trying. Thank you.